Welcome to Pause for the Truth, where you can sit back, relax, and hear an honest dialogue about health, wealth, legal, and social issues. The hosts are Dr. Rogers Kane, family practice physician, and Jocelyn Turner, health education consultant, with co hosts from the Northeast Florida Medical Society and its foundation. Stay tuned for the truth about matters affecting you and your family. We're here to tell you what's really going on and why. Good evening, and good evening some more. I am your co host, Jocelyn Turner. It's a beautiful day here in Northeast Florida, and of course, I can't do this alone. I am joined by my co host, Dr. Rogers Kane. Before we introduce our guest, Dr. Kane, how are you this evening?
I am doing great. I'm enjoying the weather. I hear it's supposed to change a little bit tomorrow. Going to get a little warmer. If not tomorrow, day after tomorrow for sure. But the next couple of days is going to get warmer. I'm going to be thoroughly disappointed because, again, as I told you in the past, I can put on as many clothes as I need to when it's too cold, but I just can't take them off and stay out of jail. So,
Dr. Kane, I don't know what I'm going to do with you. I'm going to leave that one right there, right, Dr. I'm not even bring you into that, Dr. Otira. I'm just going to move on into tonight's topic, which is a very, very important topic that affects far too many people, unfortunately, including my own family. And Dr. Wachira, I think it is a topic that's misunderstood. Our discussion for tonight is entitled Every Breath Matters, Understanding Lung Cancer from the Inside Out, which will help us look beyond the statistics and into the stories, science, and solutions. November is Lung Cancer Awareness Month, and it's the perfect time to shed light on prevention, early detection, and what new treatments mean for patients and families. And we are honored to welcome our guest, Dr. John Wachira, a pulmonologist who has dedicated his career to helping people breathe easier and live longer, healthier lives. How are you doing this evening, Dr. Wachira? And
I am
welcome.
doing, yeah, thank you very much for having me. I'm going to pause and actually thank you. Thank you, Miss Jocelyn, obviously Dr. Kane and Tyrone for the work that you are doing for all of us in our community. Um, you know, Obviously before we logged in on air, you told me this is episode 200 and number three. And you guys been doing this since 2021. And I want to tell you on behalf of our community, thank you for having this platform and tackling and handling very, very crucial and important topics. Including the one we're going to talk about today, because it's platforms like this and people like you that are committed and have the consistency to address um, uh, important topics like this that's going to move the needle forward. So thank you for what you do. Thank you for having me back again. And I am doing well, to answer your question, and I'm excited to to uh, to add to your work to the best of my ability.
Thank you, and thank you again for acknowledging it. And I called you Dr. John Wachira, but I'll call you Jay Kelly
I
Wachira
love
because
it.
that
I
might
love it.
be.
Yeah, I go by Kelly. You can go call me Kelly, please. Yep.
It's so many Johns, not a whole lot of Kellys, right? I can get with that. Yeah, I
That's why I go
mentioned
by Kelly. Yep, you're right. You're right.
exactly. Dr. Wachira, I mentioned that lung cancer impacted our family because my dad was actually diagnosed with lung cancer, and that was his cause of death. He had gotten it once and then again a second time, and unfortunately, he succumbed to it the second time. So
Yeah.
it was tough. It
Yeah.
was tough watching him go through that. So without us making an assumption, let's talk about, we want people to understand what exactly is lung cancer and how does it develop in the lungs?
Yeah. Yeah. So lung cancer, or any kind of cancer, frankly, is really when normal cells change. We call that a mutation, and they become abnormal. and they start to replicate or divide uncontrollably. And when that happens, that is cancer by definition. So obviously, if this happens within your lungs, then we call that lung cancer. But frankly speaking, if it happens in your stomach, we call that stomach cancer. It all depends on the location of where these originally normal cells get mutated by whatever trigger and become abnormal and continue this process of dividing and forming similar abnormal cells. And over time, that is what forms a cancer diagnosis. Now, if they're not detected early, then of course they continue this abnormal dividing process, and that's how you develop tumors. So obviously, if it happens in your lung, now you have a tumor within your lung. And again, if it's not addressed earlier, based on some of the symptoms that we're going to talk about that most patients present with, then that's the danger of it now starting to spread outside of the lungs.
And what are the major types of lung cancer, and do they differ in how they're treated?
Yeah. So there are two main kinds of lung cancer. The first one is non-small cell lung cancer. That's the most common one. About 80% of all lung cancers are non-small cell lung cancer. And then the other 20% is what we call small cell lung cancer. Now, with the non-small cell lung cancer, you actually have other subtypes. The most common one being adenocarcinoma. This is the one that actually likes women and specifically non-smokers. There is that, kind of myth that you have to smoke to have lung cancer, but it's a very well known fact that there's a lot of people, unfortunately, who develop lung cancer, specifically women that never smoked. And then you have another kind of non-small cell lung cancer called squamous cell, and then you have other subtypes like carcinoid and lymphomas, which not necessarily lung cancer but can affect the lung. And then of course we know that any other cancer, breast cancer, colorectal cancer, stomach cancer, can travel and affect the lung. So obviously those are not lung cancers per se. They just happen to be other secondary cancers that can travel and spread to the lungs.
So how common is lung cancer among people who've never smoked?
So yeah, obviously the number one cause of lung cancer is smoking. I think if you look at the literature, it says about 85% of the etiology of lung cancer is smoking. So the other 15% is divided into different things. So one, is, believe it or not, radon exposure. And radon, for your audience, this is a natural odorless gas that is trapped within rocks and soil and groundwater. And if you have a foundational crack in your house and that rock decays, it has the probability to produce this gas that you can't smell or see. And if you don't repair your foundation or your walls over time, this gas has radioactive properties, and so if you inhale it long enough and it gets into your lungs, it can break down and actually start to cause damage to your lungs and eventually give you lung cancer. And that's not to scare your audience. This is just an education so that these are things that we can mitigate upon, right? The more we know, the more we do, hopefully. And so simple things, there are commercial, mitigation systems that come with your insurance that you can, summon to say, hey, if you have a crack in your foundation or in your walls, these are things that are repairable and could have health benefits.
It's so interesting because you only hear the cosmetic part of or structural part of those cracks and things. I've never heard that saying the potential impact on your health. That's something.
Yeah, absolutely. Yeah, there's and then of course asbestosis. That's another another cause that can be prevented, purely by just inspection and making sure that the levels are appropriate and not hazardous to either commercial settings or residential living areas. But yeah, these are certainly potential contributors for lung cancer. But back to your question, we don't necessarily have a number. I think it's in the single digits, anywhere between 5 and 9% is what it's felt to be. Individuals that never smoked that develop lung cancer. But obviously some of the factors that you and I are talking about, contribute to that, regardless of whether they smoked or not. Obviously, if they smoked and say, God forbid, they live in a house that has these other contributors, they're just kind of, adding on to a perfect storm. Yeah.
Dr. Kane, you're muted.
Yeah, that's because of the dog. He smokes up. I don't know. He acting up. Anyway, they do have radon testing kits that you can buy, out of the store. My wife always beat me up. We need another testing kit, and it's like, okay, but and we haven't detected. In North and Central Florida, Florida is not usually one of those places you have a high amount of radon, except if you want to look at it, maybe in North and Central Florida is higher than other places. But, you see it more in the Northeast U.S. and I think in other places beyond Florida. But it's still something to think about. And for those who got scared, as Dr. Kelly, as Dr. Washira mentioned,
yeah,
there are some radon testing kits available. Just in case.
I'm just like, wait a minute. I'm on Amazon right now, Dr. Washira, looking for a radon test kit. I don't know which one is. I mean, who knew that there are a bunch of them that came up? I'm just like, oh my God, never noticed.
Yeah, absolutely.
So beyond smoking, and you talked about radon, what other environmental or genetic risk factors contribute to lung cancer?
Yeah, so you're right. So there are some genetic factors, and obviously that calls for genetic testing, but it has to be individuals that, to your point, never smoked. And then this is the part where you got to gather your history from, your parents and your grandparents, and to see if they were diagnosed with this disease process, and also make sure that they never smoked. So it tends to affect individuals that never smoked, and it tends to run in families. So that's one of the things that we do during our history. When we're talking with the patient, is we go over what runs in the family, and if they're aware of anything that affected their parents or their grandparents. So there's a genetic predisposition. Pollution, like you said, is another cause or association. That's just from the air that you're breathing. And again, just like we talked about with radon, some of these toxins have the ability to damage and injure your lungs. And over time, if you're not doing anything about it, like removing that trigger or that whatever toxin that is, down the road, it could eventually lead to you having lung cancer.
Are there any particular symptoms that people should pay attention to that might indicate a lung problem?
Yeah. So the most common sign and symptom, believe it or not, is a nagging cough. And this is a cough that, you've had for a long time, that's been treated with antibiotics, been treated with steroids, and it maybe gets a little bit better, but it doesn't necessarily go away. So when we see a patient coming in with a chronic cough, your antenna kind of goes up to make sure that you're not missing anything that might be related to lung cancer. Now, sometimes the cough could include coughing up blood, and when we see that, that's even more worrisome, because technically, even with an infection and inflammation, maybe blood tinged sputum, you could see that. But when a patient comes to you and tell you they're coughing up blood, that's an alarming sign. The other common symptom is just shortness of breath. And again, shortness of breath. A lot of patients unfortunately struggle with shortness of breath for a myriad of reasons. Heart-related issues, lung-related issues, sometimes even stomach-related issues can cause shortness of breath. So you got to put your thinking cap on and tease out what's contributing, because a lot of these patients have other medical conditions, and you gotta address each accordingly so that you're not missing anything. But certainly cough, shortness of breath. Sometimes they might have what we call an atypical chest pain, because if they have a tumor in their lungs, it might be causing some sort of discomfort. And so, you got to make sure that you're evaluating that and getting appropriate testing, whether that's blood work and imaging that we're going to talk about here in a second, because that's what helps you throughout the process of investigating whether the patient is struggling with lung cancer. And then the final symptoms that we do see, and unfortunately we see this as an end stage symptom, is weight loss, unintentional weight loss. The patient will come in and tell you, "Doc, I'm just losing weight, and I'm not attempting or trying to lose weight. I'm just losing weight." So when you have those classic symptoms, certainly your threshold to investigate for lung cancer is quite high.
I remember when my dad had lung cancer, Dr. Wachira, it was so interesting to understand the disease as it progressed.
Yeah.
Because I remember when we went to see, the worst team that we could have met was the palliative care team. And I remember when my dad thought he was having a heart attack.
Yeah.
And they told him it was the cancer in his lungs, obviously, eating away. And then when they recommended that he does not be resuscitated, they did a DNR, DNR, whatever it is, DNR rather.
Yeah.
And he was like, that was just, I can just remember that as though it was yesterday. So we talk about genetics and all. I know when we've talked about prostate cancer and breast cancer, we talked about genetics and the as far as families, the family history and all. But when it comes to lung cancer, it's not the same. I think if you didn't smoke, at least the risk is not as great. Smoking is by far the greatest, strongest risk factor, if you will. Is that right?
That is correct, 100%. So yeah, smoking, like I said, is 85% of all lung cancers are from smoking. So 85%. So the other 15% is divided into some of the other risk factors that you and I talked about, whether that's genetic predisposition in individuals or families that never smoked, whether that's radon exposure, whether that's asbestosis, whether that's air pollution, and then, like we said, there's a subgroup of patients, specifically women, that don't have a family history. They just and they never smoked, but have a tendency to have this adenocarcinoma, which is the non-small cell variant of lung cancer. And again, we're not smart enough to figure out like why it likes women who never smoked, that don't have a family history of lung cancer, but clearly there is a predisposition there that needs further investigation.
Let me throw in a couple of things as a primary care guy, because I typically see him before Dr. Wachira does, and I wind up having to send them to him because that's his area of specialty. But a couple of things I just wanted to throw out, and that is the passive. I'm gonna call it passive smoker, but that's the exposure as a child to the smoke that mom and dad did while in the car and while riding. And while in the house, the secondhand smoking, that gives rise to it. The other thing that a big, I guess, elephant in the room to some people would be, so with today's legalization of marijuana, what do we stand with the risk of developing lung cancer from smoking marijuana?
Yeah. So 2 points. Yeah, I'm actually glad you talked about secondhand smoking, because I do think I forgot that piece of it. Yes, that is another risk factor that I think we need to recognize, that is just as bad as smoking. Just you know, accumulation of secondhand smoking where you're inhaling this toxin, we've seen that it's a major risk factor for lung cancer diagnosis. So that's a very, very good piece of information, Dr. Kane, and I'm glad you mentioned that, because I think I forgot to mention that. Now, to your question about marijuana, and we can even throw in just vaping, frankly. So vaping,
Yeah.
yes, so vaping nicotine, obviously you can vape other products, but vaping nicotine, we know that you're heating tobacco, you're not burning tobacco. So yes, it's a cleaner way to ingest the product, but nonetheless, the product in and of itself, is carcinogenic. So it has the ability to give you cancer. So yes, smoking cigarettes is more dangerous, because not only are you burning tobacco, but you're burning the carcinogens that are incorporated within the tobacco product. So it does give you higher chances of developing lung cancer. But vaping nicotine also, is a risk factor for developing lung cancer. Now, marijuana, on the other hand, I don't think we have really good data on it. We know for sure that vaping it or smoking it definitely injures or damages your lungs. And I cannot tell you, every time I round in the hospital, there's always like an 18 or a 19 or 20-year-old kid with a collapsed lung. And a lot of them, they don't know that smoking marijuana thins the lung. It causes something we call paraseptal emphysema, which is basically, it's a form of thinning of the lung that affects the edges of the lung, not so much the center of the lungs, which is what you see with smoking tobacco. But the thing about it is, when you thin the outside of the lung, then it's real easy for that lung to collapse in the right environment. And that's really what we see with individuals that smoke marijuana, regardless of age. Specifically when they use the bong and they generate intrathoracic pressure, where they're holding their breath. That's actually how they get to pop their lungs. And then, so it's not a pleasant illness. Collapsing of the lung is a very painful disease process, where we have to put tubes in your chest and hope and pray that part of your lung that's thinned out can heal by itself. A lot of times it doesn't, and we have to send these patients for surgery to repair those holes that have popped.
Two things I wanted to run out while we're there on that subject matter. One is smoking marijuana. One of the things I tend to see is a lot of them roll their marijuana not in the necessarily in the papers, the little marijuana papers that they did back in the old days. They rolling them up in cigar leaves, and so now you're combining tobacco to a degree with marijuana.
Yeah.
So we hadn't, like you say, we hadn't did a whole lot of enough confirmative testing on it to know exactly what's going on.
Yeah.
But the other thing I wanted to throw out was that the vaping, one of the big problems with vaping, additional problem with vaping, is that we don't know what the diluent is, what the diluent is.
Right.
Some people that was from vapor making people that were putting vitamin D oil in the vaping solution, and that I think probably, I definitely feel like it destroys some of the lung tissue. How much cancer, how big a cancer provocation it caused, I'm not sure. You may know, you probably know more about it than I do, but that's one of the big problems I've noticed and have experienced with people with vaping.
Yeah. So great point. And if you remember a few years ago, there was a season where we were struggling with a lot of vaping-induced lung injury, and you're right. A lot of that had to do with the wrong processing and addition of the wrong flavors. One of that being vitamin D, as well as others. And what we saw is the wrong amount. And again, that has to do with legislation sometimes and where some of these kids were getting some of these products, sometimes in the black market because they're underaged kids.
Right.
So they can go to the regular grocery store and buy one. So some of that, there is a black market, unfortunately, that exists because it's so rampant in our schools when it comes to vaping, because they're marketing. These companies are so smart that they're targeting our kids, and they're basically showing them that you can consume just about any product, and we'll cater to your flavor. Basically, it comes in all sorts of flavors, and so it's real easy to get it into their hands. And if they process it in the wrong way and they put the wrong things, it has the capability to cause issues. And again, I don't think we have a full understanding of what it will do. I do think this is
Right.
this is a topic that will continue to evolve over time. And I do think, to your point, I do think at some point we're going to see an association with lung cancer because of the stuff that's being put into these products, But certainly when it comes to things like pneumonias and what we call ARDS, which is an inflammatory process in people's lungs, certainly this is associated with vaping, whatever you're vaping. Because sometimes we don't know what's within the vape.
Right.
And they do, when you talk about market, they market these things, the glamorous side of doing these products. They don't tell you about the side effects.
Right.
Probably either because they don't know, they don't care, they think it's going to happen to someone else. If you're just tuning in, we are having a conversation with J. Kelly Washira, MD, Chief of Pulmonary and Critical Care with Baptist Medical Center, talking about a topic that unfortunately affects a lot of people, and they just don't realize how it's impacting our community so much. As I mentioned at the onset of the show, my dad had lung cancer, and it's not something that you want to see your loved one go through. My dad was a smoker, Dr. Wachira. He actually smoked 30 plus years and had stopped 30 years. Unfortunately, the damage, well, I think was already done, particularly back in the day when he smoked and the types of cigarettes that were smoking. And I want to talk about that briefly. And you had a great PowerPoint presentation, and we can advance that along if you'd like. But I want to just insert a quick question. I know there used to be commercials that talked about the nicotine or tar or whatever was lessened if you smoke this cigarette versus another. Does that really matter, or is the darn cigarette bad no matter which one you get?
Yeah, I think the simplest answer is that. Yeah, again, 85% of lung cancer is from smoking, and it's not just smoking any sort of form of cigarette. It's any cigarette. So I think the right answer is to say all of them are bad. Now, we do know that the menthol flavor, those are notorious for one, addiction. They're harder to stop if you smoke menthol flavored cigarettes. And also because of that, then there's kind of a little bit of maybe you could argue at a higher incidence of lung cancer. But again, all of them are bad. And I think we talked about this last time. Again, back to the marketing companies, they strategically targeted our people by marketing these products in our neighborhood to get our kids stuck on these highly addictive cigarettes. Compared to other demographics of people. So again, and we haven't mentioned that if you actually look at the statistics, even today, if you look at the incidence of lung cancer, it's actually higher in our patient population in African-American men, followed by African-American women compared to other demographics. And so again, that's why I applaud you, Dr. Kane and Jocelyn and Tyrone, for having platforms like this so we can talk about these issues, because these issues are important, and we need to know about this. So because we all have a part to play, from you and I, from an education standpoint and choices and supporting our family members that maybe might be struggling in this area, and also from a legislative perspective, just policies and pushing the agenda and lawmakers, representing us the right way, and especially when it comes to some of the stuff that we've talked about, like targeting our kids and I do think on the back end, like we talked about, when it comes to vaping, I do think we're going to revisit this down the road and see that there's probably going to be an association down the road.
Yep.
And so the time is now to attack these issues and come up with solutions that protect our kids.
Confession time.
We're gonna take our break. We're gonna have our mid-show minute, and then we'll get back to the discussion. So Tyrone, take it away.
Welcome to Pause for the Truth. Today is November 4th, 2025. This is the Pause for the Truth Mid-Show Minute. I'm glad you're here because this one matters. Every breath, every heartbeat, every hug that lasts a second longer matters. We're talking about breast cancer with love and focus on Black and minority communities. The story isn't just stats. Numbers are the echo of real lives. In the U.S., Black women are slightly less likely to get breast cancer than white women. More likely to die from it. More likely to be diagnosed younger, more likely to face aggressive types like triple negative breast cancer, and too often diagnosed later when options shrink and the fight gets harder. That's not biology alone. Access, trust, cost, bias, time off work, childcare, fear. It's the I'll go next month that turns into next year. It's the pain you ignore because everybody needs you. So here's the truth wrapped in care. Early detection saves lives. If you're 40 or older, talk with your clinician about mammograms. Many guidelines say start at 40, every 1-2 years. Mama, auntie, sister, daughter. Ask about starting earlier. Genetic testing, tailored screening, know your normal, new lump, skin dimpling, nipple changes, discharge, swelling, pain that won't let up. Don't wait. Self-awareness isn't a diagnosis, but it's your first alarm. Money tight, no shame. CDC's National Breast and Cervical Cancer Early Detection Program. Local clinics, church partnerships, mobile mammography units. Call, ask, show up. Your future self is begging you to. Lifestyle isn't everything, but it's something. Move your body. Keep a healthy weight. Drink less alcohol. If you smoke, let today be your turning point. If you can breastfeed, it can lower risk. Fellas, listen up. Men can get breast cancer too. Lump behind the nipple, changes in the chest, discharge, get it checked. Be the ride, be the note taker, be the hand to hold. Sis, you are not a statistic. You are a story still being written. Get a second opinion if something feels off. Ask about clinical trials. Our participation shapes better treatments for us. Exhale with me, then inhale the decision to act. Book the appointment. Text a friend to check on hers. Share this with someone you love. Every breath matters. Screening, support, science. I'm rooting for your life, your laughter, your long future. This is Pause for the Truth. I'll see you next time.
I think Tyrone got confused. Even though there was a few things in there that reference in terms of stop smoking if the people get breast cancer. Since we talk about smoking. But I think that just was an error. He teared up the wrong one. What I will add, confession time. I remember how they targeted the Black community with menthol cigarettes, because I fell victim way back much earlier years. It didn't last long, but still, it was much easier to smoke a menthol cigarette because it went down smoother than it was those harsher Camel and non-mentholated cigarette.
Yep.
So I just wanted to make sure that we let people know that, yeah, while it may, your lungs may, and your trachea may accept it better in terms of trying to inhale it, it's still just as dangerous
Right.
as the non-menthol cigarette. Probably
Right.
even more dangerous, to be quite frank with you,
Yeah.
because you can smoke more of them and not feel so irritated.
Right. And then when you're ready to quit, it's harder for you to quit on those menthol flavored cigarettes than the non,
Yep.
menthols. They have that kind of addicting quality in them.
Vincent and Hedges.
Dr. Richeri, I wanted to ask you about screening. How important is early screening, and
Excellent.
who should be getting screened?
Excellent. Very, very important question. I'm glad you asked me that. So a few other statistics in regards to lung cancer. Lung cancer is the third most common cancer of all cancers. But with that said, it's the number one cause of all cancer-related deaths.
Yes,
So I want you to think about that. So it's number 3 behind breast and prostate, but it is the number one cause of death when it comes to all cancers combined. Okay, so it is a very, very important topic. So and I guess the biggest take-home message for your audience is really what you just asked is early detection, because when it comes to any kind of cancer, specifically lung cancer, especially knowing those facts, nobody wants to have lung cancer, but if you're going to have it, you want to have early stages, because early stages are curable. So early detection is key. And believe it or not, we never used to have a screening program up until recently. Over like the last 10 years ago, I think I would say arguably about 10 years ago, there was a trial that was done that's called the National Lung Cancer Trial. And what they did is they randomized high-risk individuals that we're going to talk about here, that smoked for a long time, either were still smoking or smoked within the last 15 years. And they've had to have smoked for a long time, and they randomized them to get what's called a low-dose CT scan. This is not your regular CAT scan that you get when you go to the ER and you have chest pain or shortness of breath. It uses much less radiation, and they compared that with just your run-in-the-mill X-ray, and what they found is low-dose CT scans of your chest actually lowered your mortality by greater than 20%. So now there is a national program, and I'm sure Dr. Kane and I, we enroll our patients into this program that qualify for it, where we scan them once a year to basically screen them for lung cancer. Because again, if you're going to catch it, you want to catch it between stage 1 and stage 2, because that's resectable and potentially curable. Now, in terms of who qualifies for this screening, there is an age limit. So you have to be between age 50 and 80. So 50 and 80. You must have smoked for 20 plus years. You could be a current smoker, or you could have stopped smoking. And if you have stopped smoking, you have to be within the last 15 years. So if you just go talk to your primary care doctor, if you meet that criteria, they'll walk you through whether you qualify for it or not. But again, this is something that's very, very important for our community, for folks to know that there is a program that exists today, that they can talk with your primary care doctors and can be enrolled with this annual scan that is a low dose, has real low risk when it comes to radiation-induced issues, and can make a world of difference, because the sooner you can diagnose patients, the better you can mitigate and, again, like I said, cure them.
One point I'd like to bring up, Mr. Turner, before we go too far, used 20 pack. I mean, he used 20 years as being the
20 pack year history. Yep.
Yeah, but the thing that we look at as primary care guys, and Dr. Richeri also looks at, is that just because it's not a what's the word I'm looking for? It's not an actual year to year, 20 years.
Yeah. Yep.
We have to look at the fact like how many packs a day did you smoke?
Hmm.
And
How
based
long?
on how many packs a day you smoke, we extrapolate that to mean, a year. So if you smoke 1 pack a day, is 1 pack years. Okay, so
Correct.
you need
Correct.
20 of those. And if you smoke 2 packs a day, you only need to have smoked 10 years and not necessarily 20 years,
Yeah.
and so on
Yeah.
and so on. That's the math. Just
Yep.
so people don't walk away thinking, oh, well, I never smoked more. I only smoked 15 years.
Mhm.
Yeah.
And think that
Yeah.
it's okay to walk away from that.
Yep. Yep. Great point. Great point. Yep. It's a
So,
pack year history. That is correct.
so Tyrone, if you could bring up Dr. Wachira's PowerPoint presentation, because it was such a good presentation. What slide do you want us to advance to, Dr. Wachira?
All right. Let's see. Yeah, you can go past that one, Tyrone. Yeah. So I think we've already talked about the diagnosis. This was just a picture showing a normal lung compared to one that has lung cancer. These are some of the statistics that we threw out that affect us as a community. And this again, you know, these are some of the factors that I think contribute to some of those statistics. And, we've talked about this. These are the different kinds of lung cancers. We talked about the small cell lung cancer versus the non-small cell lung cancer. And we said that the non-small cell lung cancer is the most common kind of lung cancer. About 80% of all lung cancers are non-small cell. And you divide that into 3 kinds. You have the adenocarcinoma, which is the one that likes non-smokers and specifically female. It can affect smokers, don't get me wrong, but that's the one that we tend to see in female non-smokers. And then we have, these are just kind of the common causes and risk factors across the board, not just in African-American ethnic groups, but this is just across the board from an all-comers standpoint. Smoking, like we said, causing 85% of the cases, secondhand smoking being another contributing risk factor. We talked about radon and pollution, and then we talked about the genetic predisposition. That's an area of research and interest. And we said anybody can have lung cancer. You don't have to have smoked. That's a very, very important piece of information. We went over some of the common signs and symptoms, and we said that cough tends to be the predominant symptom. But then when you couple that with coughing up of blood, that is a significant red flag that needs further investigation. We said shortness of breath is the second most common sign and symptom. Sometimes you can have an atypical chest pain depending on the location of the tumor and the size of it. And then we talked about weight loss. Now here, the point of this was there is an algorithm that we follow. When the patient comes in with, that has the right risk factors that we've talked about, and they're telling you the signs and symptoms that are of concern. What we tend to do as far as next steps is imaging. Initially we start off with a chest X-ray. That's the simplest thing that we do. And if you find something that is abnormal, what we tend to do next is get a CAT scan. And then CAT scan is a much better picture. It's thinner slices of the lungs. You're able to appreciate pretty much all parts of the lung. Sometimes you can miss things with an X-ray because it's basically a picture that is in front of you and behind you, so it doesn't necessarily look at all the subsections of your lungs. So if you see something abnormal with your CAT scan, then the next step is to do what's called a PET scan, and a PET scan is a whole body scan that uses a medicine that we call a radioactive medicine that we inject in your vein. And what this medicine does is if there's any abnormal cells within your body, they take up this medicine, and you can see that from the PET scan images. And so if you do that and you see something that is abnormal and was able to take up this radioactive medicine, then you need to proceed with the next step, which is a biopsy. And this is kind of where I come in, because a lot of these patients, will end up needing some sort of what we call a bronchoscopy. A bronchoscopy is a procedure where we go through your lungs and identify or find where the spot is and get some samples so that we can further analyze those cells to make sure they are cancer or they're not. And if they're cancer, you want to find out what kind of lung cancer it is, because treatment and prognosis depends not only on what kind of lung cancer you have, but also obviously the stage of lung cancer. And I think I do have an example at the end of this presentation of a patient that presented to me last week, that I went through that whole process of identifying what was wrong with the patient and eventually giving the patient some answers. Now, this is basically talking about screening, which I think we've talked about, there is a lung cancer early detection program that involves getting these annual low dose CT scans to screen the appropriate patient population, because the key here is early detection. If we're going to move the needle in this terrible illness, it's one of the things that's going to leave a dent is early screening, so that we can identify these spots earlier, so we can act upon them sooner than later. When it comes to lung cancer stages, there are 4 stages.
Sure. Before you get into the stages, let me just ask one quick question. Liquid biopsy.
Yeah.
For some of us that don't quite understand what that is, can you tell us what that is?
Yes. So these are the nuances of lung cancer as well as other cancers, really. So a liquid biopsy is a blood test that now we're using, to diagnose cancer. You can't actually diagnose lung cancer in patients that are too high risk for a biopsy. A biopsy is still gold standard, but we have patient populations that have so much emphysema, they're already on oxygen, and they're too high risk for general anesthesia as well as a biopsy. And so after you have a multidisciplinary team discussion and it's agreed upon that the benefits, or I should say the risk, outweigh the benefits of proceeding with a biopsy, sometimes you can pursue a liquid biopsy to see if you can identify tumor markers or cells that can help you with diagnosis. But it's mostly used for response to treatment. Once you have a patient that you've done a biopsy and you have an answer or what kind of lung cancer they have, and you start them on appropriate treatment, whether that's chemotherapy or targeted therapy or immunotherapy, it's a pretty good test to see if they're responding to that treatment. So if you see the levels rising, then obviously they're not responding to the treatment that you have them on. But if you see the levels improving, then clearly it's showing you that the patient is responding to the treatment that you have them on, and that's always a good prognostic marker.
Good. Okay, yeah. I'm sorry. Go ahead.
Absolutely. So this slide is just highlighting the 4 stages of lung cancer, and lung cancer staging is very, very complicated. We use the tumor size, the location, involvement of what we call lymph nodes, and whether or not the cancer has spread outside of the lung. We call that metastases. So stage 1, and this is just me generalizing it. It's significantly in depth than what I'm going to describe here. But stage 1 basically involves just the tumor in the lung without any involvement of the other lung or involvement of the lymph nodes. Stage 2 is the tumor involving the lymph nodes. And usually those lymph nodes are closer to where the tumor is. Stage 3 is involving the tumor involving the lymph nodes that are in the thoracic cavity. We call that the mediastinum. And then stage 4 is where the cancer has either spread to the other lung or it's spread to the lining of the lung. We call that the pleura. or it's actually spread outside of the lungs, and that's what we call metastases. So obviously, the higher the stage, the worse your outcome. Remember we talked about screening, and again, screening targets the patient in stage 1. You want to catch them in stage 1 and stage 2 because those patients qualify for surgery. Now we're going to talk about treatment options. Those are the patients that qualify for surgery because you want to get in there and actually remove that part of the lung that's affected by the cancer. And a lot of these patients, you can actually cure them if they're in stage 1 and stage 2. The patients in stage 3 and 4, those are the ones that unfortunately they tend not to be surgical candidates. And so what you're looking at with these patients is radiation therapy, where you're trying to target the cancer using X-rays and energy and beams. Sometimes you can use the traditional chemotherapy. These are the IV medicines that are targeting the cancer. But the other nuance of lung cancer has been these targeted therapies, or some of them, we call them the immunotherapies. And some of them can be pills, believe it or not, and some of them are IV, but a lot of them are pills. And they have really, really advanced treatment of lung cancer and outcomes. We have patients with stage 4 lung cancer that take a pill, and they're living 5, 10 plus years. 10 years ago, that was never the case. If you had stage 4 lung cancer, your mortality in 5 years was almost, close to 100%. And now you have these individuals. I have a patient that I diagnosed with stage 4 lung cancer 8 years ago, and he comes to see me once a year. That's how well he's doing.
Yeah, a friend of mine was diagnosed with. He was our first guest on the podcast, Dr. Kane. He had stage 4 lung cancer and brain cancer, and he's doing amazing. And he did immunotherapy.
Yeah. Immunotherapies have been godsend. They've just completely revolutionized treatment and outcomes. They're just unbelievable medicines with very little to few side effects compared to your traditional IV chemotherapy. In terms of infection and blood counts and things of those nature. And they're still coming up with more. Thank God. So
that's why research is so important.
Yes.
Especially those that have reached that. Any research in lung cancer is very important. But definitely for 3 and 4, stage 3 and 4, because they can help provide energy for cure for future generations as well as yourself if we're lucky.
Yes. And so these are just prevention strategies that we've already talked about. If you're smoking, stop. We have lots of strategies to help patients now quit smoking. So that's been another area that we've improved. Avoiding secondhand smoking, especially when it comes to our kids. Some people will smoke in a car, with kids in the back seat. Those things are quite dangerous over time. We talked about radon kits, whether these are, commercial kits or, associated with your insurance, just doing your homework and making sure that, if you have any seal in your foundation or the walls, those are taken care of or sealed. And then simple things like just being healthy, just stay active, eat the right things, make sure there's no pollution, where you live, where you work as best as you can, managing what you can and controlling what you can control.
I like that. Say that again. Managing what you can and control what you can't control.
Yeah, absolutely. And
so I think I messed up on this one. I don't know if the next one has all the information on it.
Yeah. So I think what I wanted to end with, this is just a typical story. And I think for all the physicians that are part of the audience, this is just kind of how we learn. This is a patient that came to see me just last week, an 80-year-old Caucasian female that's not a smoker. Here we go again, who just presented with a cough. She had, her other medical conditions included asthma, high blood pressure, some cholesterol and some acid reflux. She had been treated with couple rounds of antibiotics, and the cough just kind of persisted, did not get any better. And so then she was sent to me. So then, the first thing, like we said, is after talking to her, I got a chest x-ray. And the chest x-ray, next slide, if you can go to the next slide, Tyrone. There we go. If you look at a chest x-ray, you can see on the right side, there's a little spot. I've highlighted that with the blue marker. She had a spot on the right side that's not there on the left side. So that was initially concerning that something was going on. So I proceeded with the CAT scan, which is the next slide. And you can see here, again, on that right upper lobe, there seems to be a spot that's not being shown on the left side. So that was concerning. Even though she's a non-smoker, she has this spot in her lungs. She's been battling this cough that she's been treated with rounds of antibiotics, and it's not getting better. So then the next step was to get a PET scan, like we talked about. And if you remember what I said with the PET scan, is we administer this radioactive medicine through the vein. And if you have any sort of abnormal tissue, it takes up this medicine. And sure enough, in this patient, you can see that spot on the right upper lobe took up the medicine. And so obviously that's concerning. Now, the caveat is if you have an infection or inflammation, it could look like this. So just because it lit up, just because your PET scan is abnormal, it does not mean that you have lung cancer. That's why the next step is very important, which is the biopsy. And here is a picture of me doing that biopsy last week. I think I did it on Thursday, and you can see my scope. And this is a good place for me to stop and say, we've advanced so much, even in my field, when it comes to how we do biopsies. Now we're using what's called a robotic bronchoscopy, and this is a scope that can basically traverse any part of your lungs, and so this is a good kind of plug to primary care providers to know that now as lung doctors we can actually biopsy any part of your lung, because now we have these scopes that can basically travel all the way down to the pleura. Because usually a traditional bronchoscopy that's handheld, you can only go so far because you're using your hands. So these robotic bronchoscopies, you're basically driving the scope with a joystick. So I'm not actually holding the scope myself, and we're beginning to do more and more of these, and we're getting better at them. And I think pretty soon we might be doing all lung biopsies, regardless of where they are in the lung. And this is a good example because this spot was all the way to the periphery of the lung, and you can see my scope as well as my needle sticking out, getting some samples of this tumor. And then the next slide, I was able to find the answers for this young lady, and unfortunately she has that adenocarcinoma. And if you remember, I said adenocarcinoma is the kind that likes women that don't smoke. And here's a perfect example of a lady that never smoked, and unfortunately she has non-small cell lung cancer that is adenocarcinoma. The good news is everything, the PET scan, if you remember, the only thing that was abnormal was just the spot. So this is a patient that will qualify for surgery. And I'm not just talking about surgery, I'm talking about cure. This is going to be a patient that once we do the surgery, because that's all most likely she's going to need. She might need some chemotherapy, who knows? Sometimes they like to do that after the surgery. But bottom line is, this is a patient that's going to go back to being cured because we caught this early enough.
I remember the days when we had to, a tumor like that, you'd have had to do either open biopsy or just address it from the side.
I know.
If you look at the picture that you showed, you saw a safety pin in there.
Yeah.
It shows how small the scope is.
Yeah.
To be able to matriculate or move through the lungs to get that biopsy. Yeah. I think that's an excellent picture, even though it may look a little bit challenging to some non-clinicians.
Yeah.
A little safety pin.
Yeah. Yeah.
That's
No,
a-
great point. Great point. I mean, I've been in practice, Dr. Kane, for the last 8 years, and again, even when I trained 8 years ago, all we had was the endobronchial ultrasound was just coming up,
Right.
and the endobronchial ultrasound EBUS, replaced the mediastinoscopy that we used to send
Yep.
patients for, which is, and the Chamberlains that you're describing, which a lot of these were, you have to be in the hospital to get these surgical
Yes.
procedures for a biopsy, right?
Right.
And now the fact that we can do a same day scope, where you come in like you're getting your colonoscopy, and within an hour you're going back home.
Yep.
And not only did I diagnose you, but we staged you at the same time. So
Yeah.
basically, we an hour and a half, we are doing all that work and basically handing you over to the oncologist to treat you. It has revolutionized the practice. And to your point, it's only getting better because now we got, even with the robotic bronchoscopy, this is a relatively new thing. Even when I trained 8 years ago, I wasn't trained to do robotic bronchoscopies because they did not exist. This has happened over the last 4 or 5 years now, where now the bronchoscopy, you don't even have to hold on to it. You can drive it like a video game,
Right.
and you can basically travel the entirety of your lungs. It's just it's groundbreaking, mind-boggling, but again, good care for the patient at the end of the day.
That used to take weeks
Yes.
to a month or so just to go on ahead and stage it and do all of that stuff. And to
Yeah.
hear that you guys can literally do that in about an hour and a half
Yeah. Yeah.
is amazing. I don't want anybody to take comfort. Like, well, if I smoke, they can take care of it in an hour and a half. No, we may
No.
be able to diagnose it in an hour and a half.
Right.
We're
Right.
going to cure it in an
Right.
hour and a half. Stop smoking.
Right. Yep. That's a completely different process that you don't want to go through. Yep.
Right.
Yeah. So very good. Yeah. And so I think my final slide here is just, again, reiterating just the importance of awareness and knowledge. And again, I'm going to keep putting a plug to this platform and Dr. Kane and your team and Jocelyn and Tyrone for platforms like this, that we can talk about these issues that do affect us from a personal level. Miss Jocelyn, obviously, you've talked about your dad, and just again reemphasizing that yes, lung cancer affects mostly smokers, but again, it affects non-smokers as well. So we need to be aware of that, because there's that kind of stigma, where we just think, yeah, they smoke, they deserve to. No, there's a lot of people dealing with lung cancer that never smoked. And so we talked about screening. Please talk to your primary care doctor if you ever smoked. It doesn't matter for how long, just talk it over with them to see whether you qualify for this screening program, because it will literally save your life. And then encourage your loved ones who are smoking that we have plenty of options out there to even help them reduce. To me, even reducing smoking is a win. I tell that to my patients all the time. It's like, ideally I want you to stop, but even cutting it in half for me is a win, because if you remember what Dr. Kane said, it was a 20 pack per year history. So it's how much you smoke, so, and again, early detection will save your life. And then my favorite slide is the next one.
Tyrone?
There we go. Yeah. I'm a proud girl dad. Yeah.
I can see why. He's a beautiful kid.
Yeah,
They
they're
are
awesome.
so adorable, so
Thank
cute.
you.
Well, thank you so much, Dr. Wachira. This was absolutely amazing. You just gave it your summary, but do you have any more final thoughts as we end tonight's discussion?
Again, yeah, I'm gonna sound like a broken record. Again, thank you for having me back. I appreciate the confidence. I appreciate what you guys do for our community, and we remain committed, just like you are, to continue this good work. That's first and foremost, and then number two, like I said, this is lung cancer, like I said, is the third most common form of cancer, but it's the number one cause of cancer-related deaths. And we're not just talking about in the United States; we're talking about in the world. So it's a very, very important topic that I think we need to continue to address. I do think there are some, there's some factors that that include, systemic issues, institutionalized issues, legislative issues, but also personal issues. We also have to do our part. I think personal accountability is, okay, what is it that I can do better? For me as a lung doc, some of the statistics that I'm saying, I said that African American men, if you look at the incidence of lung cancer, we're the number one group. And then right after that is my African American sisters. So clearly there's work to be done, and it takes me, and it takes platforms like this, and it takes us going back to our families and seeing who's struggling in that area, and seeing how we can help them, not judge them, not put them in a box, say, you know what, that's your personal choice, you can deal with the ramifications of that. It's just caring for our neighbors and loving them like we love ourselves, and continue to talk about this issue and doing the best that we can.
Thank you so much, Dr. Wachira. And Dr. Kane is probably already going to tell our audience this, but so I'm going to shut up and let him give his final thoughts. Go ahead, Dr. Kane.
Lung cancer is a very devastating disease. As Dr. Wachira said, it is the number one killer as far as cancer is concerned. Number one killer. All right, so we need to pay close attention to it. But we didn't talk about smoking cessation this evening, but I'm going to briefly mention it right quick. Smoking not only causes lung cancer, but you can get pancreatic cancer from it, bladder cancer from it. You get oral cancers from it. So you got to be cognizant of all of those, including esophageal cancer. Of course, they can still kill you as well. COPD, or chronic obstructive pulmonary disease, chronic bronchitis, emphysema, those things can also kill you as a result of smoking, because we couldn't get into everything. So I'm just briefly summarizing.
And heart disease, which is the number one killer.
Disease. Oh, yep. Heart disease is a big, cardiovascular disease, number one killer. And we ain't talking about cancer, we're just saying number one killer, period. So, but smoking contributed a significant amount to as a killer, a co-killer, for lack of co-conspirator to heart disease. We didn't talk about the improvement in terms of smoking cessation, but again, go back to asthma, hypertension, diabetes. And then there are resources, real quick, that we can go out there and help with your smoking cessation. First of all, talk to your primary care and your pulmonologist about smoking cessation, what's available out there. There are websites out there that you can go to, 1-800-QUIT-NOW, and the CDC has some tips for smokers and former smokers, and so you can go to their website. And then finally, Florida Tobacco Free Florida program. That's a bit redundant, but Florida Tobacco Free program for Florida. So with all that being said, I hope our audience have paid close attention. If you're a smoker, stop it. If your family member is a smoker, stop it as best you can. And if you were a former smoker, talk to your start out with your primary care, and then get a more detailed discussion as well, and be open about it with your specialist, i.e. the pulmonologist, or in layman's term, the lung doctor, which is what Dr. Wachira is, the lung guy.
Yep.
Thank you, Dr. Wachira, and thank you, Dr. Kane. And as Dr. Kane mentioned, there is the Tobacco Free Florida. You can receive a free 4-week supply of nicotine patches, gum, or lozenges, and just call 1-877-YOU-CAN-NOW or 1-877-822-6669. Again, thank you, Dr. Wachira, for helping us see that every breath truly does matter. Your insight remind us that awareness, early screening, and honest conversations can save lives. To our listeners, if you've been putting off that doctor's appointment, or if you're worried about a cough that won't go away, let tonight's conversation be your reason to act. We also want to recognize the families and caregivers who walk this journey with courage and love every day. Remember, prevention and early detection start with knowledge. So share what you've learned tonight with someone you care about. Join us next time on Pause for the Truth as we continue exploring the issues that shape our health and our communities. Until then, take care of yourselves and each other, and don't forget to pause for the truth.
We appreciate you spending time with us on Pause for the Truth. Ms. Jocelyn Turner and Dr. Rogers Kane are grateful for your support. Don't forget to like us on Facebook, catch us live on Twitch, and most importantly, subscribe on YouTube. A big shout out to Tyrone Jackson at Call Tyrone IT Services for keeping us connected. Join us every Tuesday at 6:30 p.m. Eastern Standard Time for more enlightening discussions. Thanks, and see you next week.